Yeah, as a part of Decoding CTO, I'm bringing a case of post-CABG CTO which we have done recently. So my patient is a 72-year-old status post-CABG, done 10 years before, had LIMA to LAD, SVG to OM and SVG to RCA. SVG to OM and RCA was a gem graft. This patient came with exertional angina and also recent unstable angina with syncope. At the time of acute coronary syndrome, he had moderate LV dysfunction, which subsequently improved to good LV function. He is diabetic and hypertensive. So angiogram was done showing LMCA mild disease and LAD graft was patent. There is a tight lesion calcified in proximal LAD followed by a big septal, followed by a good septal, which is filling, probably PDA. But there are dominant epicardial collaterals which are also coming from LCX. So there are two epicardial collaterals, one from distal LCX, one from the OM, so last OM, so which is connecting PDA. So this is the injection of right coronary artery, which is showing a total occlusion, and we can see the chunk of calcium which is moving along with the vessel. And this is the SVG to diagonal OM gem graft. You can see this is a gem graft. This is at the diagonal anastomosis, and this is a OM anastomosis, which is quite patent. And it also filling PDA from a collateral. So we can see here. So this is the gem graft, and OM is basically filling PDA, and which is filling distal RCA. So distal RCA is well visible through injection of SVG to diagonal and OM. So we can see this is the PDA, and which is filling right coronary artery. Yeah, this is right coronary artery. So coming to the right coronary artery, distal vessel size. So we can appreciate in a post-CABG injection. So the distal vessel size, this is the distal vessel size, but we can compare it with the pre-CABG. You can see here. So it's a very big vessel with almost four branches, including PDA. So that says it's a significant territory. That is the reason always go through pre-CABG angiogram while preparing for decision making before writing off that this vessel is small and insignificant. So CT angiogram was done outside, thinking distal RCA size and branches were not significant, just to understand how the distal territory was. But had they gone through the pre-CABG angiogram, that would have made everything clear. So anyway, what CT showed is a lot of calcium in right coronary artery. You can see. So these are the sections at that level, and you can also see there is a significant chunk of calcium, which we can compare with your angiographic calcium. So there is a chunk of calcium sitting in the wall of the vessel. So you can see there is almost nearly 240 to 260 degrees of calcium at this junction within the right coronary artery. And calcium is also there at this level. And next level, you can see here. So this is the point where there is no calcium. From here to here, calcium is there almost in every place, but from this point there is no calcium. We can see here cross sections, and the vessel is around nearly 1.9 millimeters. So if I go for antegrade dissection reentry, I think this is the right place for reentry. As there is no calcium, reentry becomes quite easy. So CT delineates clear zone for reentry in ADR. This is the anatomicogram for the patient. You can see it's a RCA, total occlusion with chunk of calcium within the CTO throughout. And from here there is no calcium. There is a clear zone for reentry in case of ADR. and there are collaterals, there are septal collaterals, there are two epicardial collaterals. One is from distal LCX to PL, and another is OM to PDA, which is filling through the venous bypass. So coming to the CTO, so it's a kind of tapered tip and a long lesion. So, and there is a lot of calcium present, and yeah, distal vessel is okay. So basically it's a JCTO2, and as the tip is not tapered, so we can always, as tip is tapered, we can always go with antegrade wire escalation, and but the chances of antegrade wire escalation working in this patient is a little dismal. It may stuck in the middle. Then if it stuck in the middle, then at the calcium, then we can go retrograde either through septal or epicardial collaterals. If that doesn't work out, then we'll come back and we'll close it in ADR. So these are the collaterals. Yeah. So during procedure, yeah, we did a dual injection. So the problem with dual injection is, you can see here, so the distal RCA is not filling, so which I clearly mentioned already. So that zone of distal RCA is filling from venous graft, you can see here. So it's filling from the venous graft. Unless you see this vessel, so your wiring becomes very difficult. So that's the reason ideal for this case is a triple injection, or if you want to give a dual injection, so inject into the venous graft. Anyway, in this case, I thought of going ahead with antegrade wire escalation, and if the wire progresses till distal cap, probably then I'll switch my left catheter into venous bypass and then inject. So we started with Miracle, as there is a lot of calcium, so, and I was not comfortable with Gaia wire. As anticipated, Miracle went and stuck in the middle of CTO. So as I mentioned, see, you can see here there's a lot of chunk of calcium at this level. So exactly at that level, Miracle got stuck. So as we are stuck in middle of CTO with antegrade wire escalation Miracle 6, we decided to go ahead with retrograde and choice of collateral for retrograde. So we have totally occluded SVG2 RCA and septal collaterals and epicardial collaterals, but not in AV groove, and epicardial collaterals in AV groove. So obviously the first choice in this patient for me is the septal collaterals, as SVG2 RCA is chronically occluded and the only stump is visible. So we went into septal, first septal with the cyan blue wire, and I dilated, as the donor vessel is deceased in the proximal area. We dilated with 2x12 and then 2.5 by 15 millimeter balloon, and then we took Caravel into the septal collateral. So, and then we injected, we can see, I couldn't see a clear connection through microcatheter injection. That's why we went ahead with surfing with cyan wire. And yeah, but unfortunately we couldn't cross into PDA. So we had, these are the different positions we have got, but we were not comfortable. So the problem is visualization of septal collaterals is a challenge in post-CABG because of the multiple collaterals. So, and many times we may end up in surfing, and we may even end up in, yeah. So as I was not successful in crossing septal collateral, we went ahead and explored for epicardial collaterals, one through the OM. Actually that was filling well from venous bypass, not from antegrade injection. So I couldn't make out anything here. That's mainly because it is filling from venous bypass. And I looked for epicardial collaterals from distal LCX. It is there, but it's very thin and it's not looked interventional collateral. So always avoid thin AV groove epicardial collaterals in post-CABG patient, because any perforation can lead to catastrophic consequences, as patient may go into very localized tamponade in the posterior AV groove. It can cause LA tamponade. So, and that's the reason we shifted to ADR. Points to make sure before switching to ADR are locate reentry zone and plan proper visualization of reentry zone either by dual or triple injection, which matters a lot. Antegrade guide catheter support has to be enhanced, and where to start dissection and what technique has to be decided. So in this case, we located reentry zone by CT already, which I have shown, and proper visualization basically comes only when I inject into the venous graft. In this case, once my dissection goes down and once my I reached my reentry zone, probably I have to go to venous bypass and inject into venous bypass. That was the plan. And you can see this is the reentry zone. So yeah, and increasing guide catheter support. So antegrade guide catheter support can be enhanced by microcatheter tapping technique. So I took a 2.5 balloon and trapped corsair, antegrade corsair in the proximal RCA. So this gives immense support for any dissection strategy, usually the knuckle wire technique. So, and where to start dissection? See, always start dissection. So this is the proximal end of CTO, proximal cap of CTO. Always start dissection 5 to 10 millimeter beyond your proximal cap, so that you are not creating any space here, so that your dissection space is not connected to aortic pressure, so which doesn't allow expansion of the subintimal space, because that is very important. We have only a distal reentry zone of 1.7 millimeters in CT scan. So if your subintimal space is connected to aorta and expanded, then your reentry becomes very difficult. So this is key. So that's what we did. We started knuckling here, and knuckle is going down. You can see this is a gladius wire 1/4, and yeah, this is knuckling. So knuckle is just getting advanced. You can see the knuckle is moving along with the vessel architecture, so which says it is within the vessel. In fact, knuckle is just passing through the calcium on both sides, in both views within the calcium. So that in fact said probably it is going in the true lumen. So, and after crossing CTO, this is my re-entry area, which I already planned, but the knuckle was just advancing without any resistance. That's when we realized probably it is within the true lumen. Then I pulled my wire out and advanced microcatheter there, and then did a position check. So we took a wire and we entered wire into multiple branches. You can see here also. So it's going into multiple branches. So I'm again going back. I'm going into AV groove branch. So that says I'm within the true lumen. So we shouldn't inject unless we are sure about lumen. If you inject, you're going to cause hydrodissection and your procedure will end there. IVUS through, we advanced GUIDELINER. So after pre-dilatation, so passing devices is going to be difficult in this case due to extensive calcium. So the preemptive guide zilla is placed into the coronary. We did IVUS. You can see these are the IVUS pictures. You can see the catheter is always within the true lumen or within the calcium. So you can see here it's in the true lumen. So it's in the true lumen. So clearly the IVUS catheter, clearly the knuckle went through the true lumen and reached true lumen. So there is no subintimal entry in this case. That can happen in few of the knuckle wiring cases. Especially, I think retrospectively in this case, as the CT showed, calcium is within the wall and almost it's like circumferential. So mostly knuckle preferred to go through the intima rather than subintima. So, and we can also see good breaks within the calcium in this sections, and which clearly says, you know, most likely there shouldn't be any issue with stent expansion. So yeah, this is the first injection, and subsequently we stunted this RCA with 3 stents, and you can see this is the final result. And you can also compare the vessel size with the pre-CABG angio, so which clearly says it's all a negatively remodeled vessel, which definitely comes back to normal in next 3 to 6 months time. So yeah, this is the IVUS, final IVUS. You can see the distal reference is around 4.7 mm square, and this is 6 mm square, and nearly 7, and 8, and also here around 9. So ostium is around 9 mm square. So learning points from this case are: post-CABG status increases complexity of CTO PCI. Thorough pre-procedure planning is needed to reduce complications and also to increase success rate. Dual or triple injection should be decided for adequate distal vessel visualization, which is very, very important for a successful antegrade wire escalation or antegrade dissection reentry. And points to ponder before switching to ADR is: define reentry area and visualize, enhance your guide catheter support, and also decide on your dissection strategy, where to start and where to end. Thank you.